So I'm going to be talking about not melanoma brown lesions that you will see from time to time in the fundus. And we're going to start with the congenital hypertrophies of the retinal pigment epithelium. A bit of a hodgepodge of a few different things, but they all have in common pigmented spots at the back that tend to be flat. And of course, the classic one is the unifocal, asymptomatic, benign CHRPE that we've all seen from time to time. Note that there are little asterisks. We'll come back to that later. From a histopathology perspective, these lesions are hyperplastic and hypertrophic, but they do show some basal growth in the majority of lesions. So just because they grow, it doesn't mean it's not a CHRPE, and it doesn't mean you should be worried, unless it's thickened, and we'll come back to that later as well. OCT now can get more peripheral than it ever did before, and you'll often see outer retinal loss, and so you may in fact have an absolute scotoma over that area. And on autofluorescence, it's always jet black. There's no hyper-autofluorescence, and that's how you know what you're looking at, using all that multimodal imaging. So that's your unifocal, bog-standard CHRPE. And of course, pigmentation can be very variable. In young patients, it's often totally black, with very crisp geographic borders, perhaps a halo, and then they depigment with time, you get lacunae, and sometimes they can be totally depigmented. So don't be fooled, CHRPE can actually not be a brown lesion. The brother of this, of course, is the grouped or bear track CHRPE, which you can see these multiple, much smaller pigmentations, grouped usually in one quadrant or one segment, but occasionally, from time to time, bilateral. The autofluorescence gives it away. Again, those jet black, no autofluorescence whatsoever over these lesions, and they tend to be much smaller. So don't be fooled, okay? These are the kinds of things you might be looking for, all totally benign. Please don't send them to your ocular oncologist. The but. So sometimes these lesions are not asymptomatic. You can rarely get secondary CNV, and they're going to require treatment in the standard way, usually with intravitreal injections if it's site-threatening. And there are rare reports of malignant transformation, but we'll come back to that and show you what you should be looking for with those. And then the final CHRPE, which isn't really the same at all, is the familial adenomatous polyposis associated CHRPEs. Very different, okay? They have these ovoid, pisciform lesions with this hyperpigmented tail, and histologically, they're totally different to their other namesakes. These are important because you could actually save a life. So this might be one of the first manifestations of FAP in an individual, and they're usually bilateral, multiple, and small. They're usually less than half a disc diameter for each lesion, but don't be sending every patient with a presumed CHRPE for a colonoscopy. They will not thank you. Colonoscopies have a risk of death associated with it. You're looking for those hypopigmented tails, those pisciform lesions. So what happens when CHRPE go bad, or RPE tumors? Okay, these are rare. Okay, RPE is quite a dynamic tissue. Any insult to an eye can cause a reactive hyperplasia that can then go through metaplasia and become neoplastic. But I'm really going to focus on the more primary tumors. You can see these nodular thickened growths that come with the CHRPE. These patients tend to be asymptomatic or develop floaters and vitreous cells, and some authors advocate that if you see a female patient with scanty vitreous cells and floaters, look for a thickened CHRPE or RPE tumor. These are very different to the melanomas that are in the choroid. They are very abruptly elevated, often quite darkly pigmented, as you can see in the image here. And then as they grow and become more nodular, they start to acquire dilated retinal feeding vessels and draining vessels, and can almost look like an angioma, but with pigmentation. And you get lots of exudation and often CMO with these. So this is when they become visually significant and they need intervention. The good news is, though, although they might be locally quite destructive, they don't metastasize, certainly if they don't become extraocular. This is a case from our experience in Sheffield. This lady actually was on holiday in Iran seeing family, and she was describing visual disturbance, had CMO, and when the examining ophthalmologist looked in, thought she had a melanoma and told her as much. But this isn't a melanoma. Look at all that exudate. Look at those draining vessels. There's something else going on here. Multimodal imaging, you can see that abrupt elevation, very different to the smooth dome that you get with choroidal melanomas. And then you've got the intense vasculature from the retinal circulation as opposed to the choroid. This patient, because of her visual disturbance, actually has been treated with pre, peri, and post-op intravitreal VEGFs, and she's actually had brachytherapy, and we'll be reporting on this case in the literature soon. So in the final group I'll talk about today is the common nevus. The choroidal nevus, if you haven't seen one, you haven't been looking in any eyes, okay? They are that common. But the actual rate of transformation is extraordinarily low if it is a simple, benign choroidal nevus with no risk factors. We'll talk about risk factors in a moment. The lesion here, there are yellow spots on them, not orange. These are not orange pigment of melanoma fame. They are drusen, and you should breathe a sigh of relief when you see them. And an OCT would help confirm that. So the aim of the game for all of us, of course, is working out, is it a melanoma or is it a prospective future melanoma that I need to watch closely? And we're very lucky now. We have 2 internationally validated ways of trying to work out what it is that's sat in front of you. They are different, they are complementary, the 2 score systems. You've got the London group system, the moles, and for those that are not native English speakers, this came up in the PHEBOS exam on Wednesday. A mole is the common vernacular for a nevus. So it's actually a very easy thing to remember, but only if you know that. And then you've got the traditional TFSOM that has changed multiple times over the years. Proximity to the optic nerve does not matter. It is defunct. We do not use it anymore, and that is certainly not a reason to be suspicious. So what do you do when you've got that nevus sat in front of you? Well, baseline imaging is the most important first step, because you'll only know if there's a change if you've got something to compare to. And obviously we are all from different countries, we have different primary and secondary ophthalmic care, and the only way any of your colleagues can know what's happening is if you've got something with a date on it from before. These lesions need monitoring, and the intensity of that monitoring depends on its risk factors. Do we need ultrasound though? Well, of course, there's that paper from the London group in 2020 saying that if you see basal growth, you'll pick up the transformed nevi, and you don't necessarily need the ultrasound. So that should be a reassuring thing for those of us that don't have rapid access to accurate B-scan ultrasound. But is change always malignant? The obvious answer is no. In medicine, there's never an always, is there? But there are certain things that are normal or physiological. Nevi grow, young adults, puberty, pregnancy. But also, physiologically, all nevi can grow at a very slow rate, provided they don't get any more additional risk factors with it. And the quoted rate is somewhere less than 0.3 millimeters per year. And of course, acquisition of subretinal fluid, again, not necessarily melanoma. You can have the so-called leaky nevus that looks benign in every other way and doesn't grow and doesn't change, and that can often be treated either with intravitreal injections or with PDT. Or you can develop a secondary CNV, and your fluorescein will show you that that's what's happening. But if in doubt, anything atypical, image them and refer them, and your friendly local ocular oncologist will step in and help. Thank you very much for your time.
I think we have time for a very, very short question, but it has to be very short. Okay, I think we'll move on.
Yeah, then we come to diagnosis of uveal melanoma, and I'm happy to announce Hanno Heimann from Liverpool to give his presentation.